So now we will talk about endometrial cancer and uterine sarcomas. The uterine corpus cancer is the fourth most common cancer in American women and the most common female reproductive cancer. So we have 400,000 new cases per year and 7,000 deaths per year. And most of the cases are adenocarcinomas, and the mean age of presentation is around 60 years of age, so more in the late adulthood. We have endometrial cancer, which is the epidemiology. The risk factors are increased estrogen exposure due to estrogen replacement therapy, obesity, anovulation, PCOS, which is high estrogen and low progesterone, estrogen secreting tumors, infertility, nulliparity, early menarche before 12 years of age, and late menopause over 52 years. Another factor is increased age. It's important also genetics. The HNPCC gene is the one associated in Lynch syndrome, and the Caucasian origin. And we have also an association with type 2 diabetes mellitus. So we have increased estrogen exposure, obesity, increased age. Obesity is part of the causes of increased estrogen exposure because fat produces sex hormones. So increased age, genetics, and type 2 diabetes mellitus. What is the pathogenesis? Well, estrogen supports endometrium hyperplasia, whereas progesterone stimulates its maturation and prepares it for pregnancy. The former, so estrogen, is a risk factor for endometrial cancer because it stimulates endometrium hyperplasia, whereas progesterone is protective, that is, pregnancy is protective, and is indeed one of the non-surgical treatments, so you can use progesterone as a treatment for endometrial cancer. Endometrium hyperplasia is the premalignant lesion of type 1 endometrial cancer. The highest risk of progression is specifically associated to hyperplasia with atypia, which has a 29% progression index, and progesterone-based treatment allows lesion regression. Simple irregular dilated glands and complex irregular and crowded glands, slightly higher risk of progression, hyperplasia are very common in 40 years old women due to high quantity of ovulation cycles during lifetime. So hyperplasia is very common for 40-year-old women, high quantity of ovulation cycles. The most common spreading pattern is through direct expansion to surrounding organs. We have then lymphatic spreading, which commonly involves the pelvic station first. Then hematogenous spread is less common, and the most common involved site in this case is the lung. Endometrial, so we have direct extension, lymphatic spreading, pelvic station first, and then hematogenous spread, especially to lungs. We can divide endometrial cancer into two main types, based on their outlook and underlying causes. We have type 1, which is the most common. It's estrogen dependent, and thus it's thought to be caused by estrogen excess. Prognosis, anyway, is usually good due to low aggressiveness and early diagnosis. Premalignant lesions are a red flag, remember. The endometrioid type is the most frequently encountered histotype among these type 1. P10 mutations are present in 32% of the patients and seem to be an early event in carcinogenesis. Type 2 is in older women, lower survival, and non-estrogen dependent. It's defined as poorly differentiated, having little resemblance to the tissue of origin. P53 mutation seems to be a late event in carcinogenesis. The papillary, serous, clear cell, adenosquamous, and undifferentiated carcinomas are the most frequent histotypes. So you have type 1, most common, estrogen dependent, good prognosis, endometrial type is most frequent, and P10 mutations. Type 2, older women, lower survival, non-estrogen dependent, poorly differentiated, P53 mutation, and serous clear cell adenosquamous and undifferentiated carcinomas, most frequent histotypes. Presentation and staging. Well, more than 95% of patients report symptoms typically abnormal uterine bleeding, which is the most important symptom. We have endometrial cells of pap smear, is a red flag as well. The tumor stage, grade, and age are the most important prognostic factors. And even if recently also molecular and genetics profiling are becoming prognostically relevant. How can we do the staging? We have this FIGO surgical stage system where stage 1 is happens in 73% of cases, the most common, and the tumor is confined to the uterus. This stage 1 can be subdivided into stage 1A, in which the cancer is only in the endometrium or invading less than half of the myometrium in thickness, and 1B, in which more than half of the myometrium is involved. Then we have stage 2, 11% of cases where the cervix is involved. Also stage 3, 13% of cases where we have an uterine cirrhosis, adnexe, vaginal metastasis, pelvic aortic node metastasis. And stage 4, in 3%, the least common one, we have distant metastasis. As the name implies, a correct staging is possible only intraoperatively, since the in-depth invasion cannot be assessed from outside. And the most common diagnosis is at early stages, as we said, because stage 1 is 73% of cases. Then, grading allows to estimate the likelihood of survival and lymph nodes involvement. So staging and grading. Due to low rate of positive nodes in G1 stage, patients' surgery can safely avoid lymph node dissection. Most oncologists, in all other circumstances, currently perform lymph node dissection, although some controversy exists with respect to small non-invasive or minimally invasive G2 tumors. Anyway, what is this grading? We have G1, let's say that we can correlate the grading to the percent and other factors to the percent of positive nodes. So if we have G1, inner third of the myometrium invasion, no extrauterine disease, we have less than 1% of lymph nodes involved. While if there are other cases, we have more involvement. Grading is associated to survival, so grade 1 is correlated with 92% of 5-year survival, grade 2, 87% 5-year survival, and grade 3, 74% of 5-year survival. How is the diagnosis and treatment done? Well, diagnosis is based on endometrium biopsy, and we have these devices which are called PPL and Vabra devices, and they have a very high sensitivity, like in the order of 99-98%. Other techniques can aid in the diagnosis. We have ultrasound, hysteroscopy, and CT-MRI. Ultrasound is used in women with postmenopausal bleeding, endometrial thickness more than or equal to 5 millimeters at ultrasound, is so in women with postmenopausal bleeding, endometrial thickness more than 5 mm at ultrasound is associated with relative risk of 4 for endometrial cancer with respect to less than 5 mm lesions. And pelvic ultrasound also allows the study of the myometrium invasion. You can have hysteroscopy, which can differentiate lesions such as endometrial polyps, hyperplasia, and endometrial carcinoma. CT MRI can be useful to diagnose metastasis and the degree of myometrium invasion. Anyway, the accuracy is still under study. Treatment: total hysterectomy and bilateral salpingo-oophorectomy is the main treatment of apparent uterine confined endometrial cancer. So, just in the case in which the cancer is confined in the uterus. The surgical procedure may be performed through laparotomy, vaginally, or via minimally invasive techniques like laparoscopy or robotic surgery. The visual evaluation of the peritoneal, diaphragmatic, and serosal surfaces with biopsy of any suspicious lesion is very important to exclude extrauterine disease. So we have to confirm that there is no extrauterine disease. We can do also pelvic lymph nodes dissection, which is performed in case of negative prognostic factors, such as stage 2, 3, and myometrial invasion. We have also an omental biopsy, which is commonly performed in serous adenocarcinoma, clear cell adenocarcinoma, or carcinosarcoma, for example, that is in type 2 endometrial carcinomas. So, omental biopsy is performed in serous adenocarcinoma, clear cell adenocarcinoma, or carcinosarcoma, which is type 2 endometrial carcinoma. And even if peritoneal cytology does not affect staging, it is still recommended to be performed. In selected cases, a more conservative treatment can be pursued. It's reserved to young women in childbearing age and young women that will become and which have a strong will to become pregnant with a tumor stage 1A G1. So these patients are treated conservatively with high-level progesterone therapy and strict follow-up. The tumor response to therapy treatment is continued for 3 months, and in case of positive response, pregnancy is allowed. Keep in mind also that diet can be a part of treatment, in order probably to reduce obesity and external sex hormones uptake. And so, if we want to be conservative, high-level progesterone therapy reserved to young women, childbearing age, with a strong will to become pregnant with a tumor stage 1A G1. So 1A, remember, is confined to the endometrium or less than 50% invasion of the myometrium. Uterine sarcomas. Uterine sarcomas account for about 6% of all uterine corpus tumors. And the most common presenting symptom is abnormal uterine bleeding. They can be divided into carcinosarcoma, which is mixed malignant Mullerian tumor, 60% of cases. The mean age of presentation is 65-75 years. So it's earlier for the other sarcoma types, and it's composed by histologically malignant epithelial and non-epithelial cells. Overall, 5% survival is poor, 25%, even for stage 1, 50%, because early metastases are common. 60% have spread outside the uterus at time of diagnosis, and in 35% of stage 1, a regional lymph node spread is present. Early hematogenous spread to liver and lung is common. In patients without extrauterine disease, there's still 40% chance of distant recurrence. Then we have leiomyosarcoma, 30% of cases, endometrial stromal sarcoma, 10% of cases. It's estrogen dependent, so oophorectomy is a treatment option. So estrogen dependent. Adenosarcoma, less than 1% of cases. It's a we have a benign epithelial component with a malignant stroma. So to repeat, we have carcinosarcoma, also known as mixed malignant Mullerian tumor, leiomyosarcoma, endometrial stromal sarcoma, and adenosarcoma. Staging is done via lymph node sampling and other cytological or pathological samples. The standard treatment is total hysterectomy and bilateral salpingo-oophorectomy. But for patients with advanced or recurrent disease, aggressive surgical intervention is unlikely to influence outcome. Bilateral oophorectomy is strongly recommended for patients with low-grade endometrial stromal sarcoma. Bilateral oophorectomy. Primary ovarian cancer overview. Epidemiology. In general, ovarian tumors are the fifth most common tumor and cause of cancer death in women, but it's rare before the age of before 40 years of age. Ovaries can be the site of metastasis too, more commonly by gastric, colorectal, and breast cancer. Which are the risk factors? Well, we have age, which is the most important factor. 80% of patients are in menopause. We have a family history which has a relative risk of free. We have a genetic susceptibility with BRCA1, BRCA2, and HNPCC, which is the one associated with Lynch syndrome. And we have atypical endometriosis, which is a low-risk factor only for clear cell endometrial ovarian cancer. We have smoke, obesity, asbestos exposure. The ovarian cancers can be classified according to the site of origin. We have a primary follicle, we have a cortical stroma, and germinal epithelium. The primary follicle is 75% of cases. Cortical stroma is 15% of cases, germinal epithelium 5%. Screening tests in ovarian cancer always failed, and this is one of the reasons why surgery is essential for diagnosis. Pathogenesis and classification. We have the incessant ovulation theory is a way to explain pathogenesis. That is, we have an ovarian epithelium rupture which stimulates the expression of proto-oncogenes that sustain re-epithelialization but that may escape control. According to this theory, inhibition of ovulation is cancer preventive. So, that could be the case in which contraceptive pills could be useful and protective because they inhibit ovulation. On the other hand, some researchers postulated that some histotypes arise from tubal epithelium seeding to ovaries. This is the rationale at the basis of performing a salpingo-oophorectomy as prophylactic procedure. We have then surface epithelial ovarian stromal tumor, which is ovarian cancers can be classified according to the behavioral pattern. Benign, no cellular atypia or stromal invasion. Borderline, cellular atypia but no or minimal stromal invasion. Malignant, like epithelial ovarian cancer. Cellular atypia and stromal invasion. These can be then subdivided by histotype. We have the serous one, which is the most common and associated with psammoma bodies and elevated cancer antigen 125. We have mucinous, which typically is not associated to BRCA1-2 mutations and is unilateral because bilaterally deposes in favor of metastasis from primary cancer of the appendix. Endometrioid is another histotype, sometimes associated with endometriosis. We have clear cell, which is the most chemoresistant, sometimes associated with endometriosis and or hypercalcemia. And then we have the Brenner tumor. So, repeat again, we have surface epithelial ovarian stromal tumors. We have different types. We have the benign, borderline malignant, which is the epithelial ovarian cancer, and they can be divided into serous, mucinous, endometrioid, clear cell, and Brenner tumor. Estrogen epithelial ovarian cancer can be classified according to molecular pathogenesis and putative origin. Type 1 corresponds to low-grade serous, low-grade endometrioid clear cell, and mucinous carcinoma. Disease course is indolent, and diagnosis is at early stage. That is, we have a better prognosis. It's possible to identify stepwise progression from a benign lesion, so ovarian cyst, perineoplastic lesion, and carcinoma. Then you have type 2, which has a high-grade serous, high-grade endometrioid tumor, carcinosarcoma, and undifferentiated forms, associated to p53 mutation as type 2 endometrial cancer, and is thought to arise from tubal cells seeding in the ovaries. No premalignant lesion is typically present, and diagnosis is late. When abdominal metastases are present, we have then a poorer prognosis. The first spreading pattern is commonly tumor exfoliation from ovaries or of fallopian tubes, followed by lymphatic spreading through ovarian vessels and broad ligament. Hematogenous metastases are uncommon, 5% of cases. Prognosis is based on grade and histotype. So we can have spreading of this epithelial ovarian cancer to the diaphragm, liver, bowel, lymph nodes, colon, pelvic peritoneal implants, ovaries, omentum, stomach, lung, and so on. So let's repeat. We have two types. Type 1, low-grade corresponds to low-grade serous, low-grade endometrioid, clear cell, and mucinous carcinoma. Better prognosis, stepwise progression. Whereas type 2 has a poorer prognosis, associated to high-grade serous, high-grade endometrioid, carcinosarcoma, and undifferentiated form associated to p53 mutation, and thought to arise from tubal cell seeding in the ovaries. Presentation and staging. These tumors are typically asymptomatic at early stages. That's why 75% of the patients usually present with advanced stage. If present, symptoms are aspecific and mostly due to compression of surrounding structures. So the symptoms are due to the compression of the surrounding structures. So we have ascites due to peritoneal implants, bloating, abdominal pain, early satiety, dyspnea, constipation, weight loss, new onset of urinary frequency or incontinence, and abdominal mass. Staging is based again on the FIGO guidelines. So we have stage 1 is limited to the ovaries, and stage 2 is limited to the pelvis, stage 3 limited to the abdomen, and stage 4 has distant metastasis outside abdominal cavity. PET-CT and colonoscopy can aid in assessing tumor spreading and bowel involvement. Diagnosis and treatment. Well, diagnosis relies on bimanual pelvic examination and transvaginal ultrasonography plus Doppler sonography. Remember that the rectovaginal septum is a common site of metastatic implants. We can have also different tumor markers depending on the histotype, which can be exploited as well. We have CA125, which is elevated in more than 80% of epithelial ovarian cancer, mostly in serous ovarian cancer, also elevated in several benign conditions, so we have a poor specificity, clinically relevant for follow-up. We then have HE4, which is less used, but screened in combination with CA125 and defines the ROMA score, that is, which is the risk of ovarian malignancy algorithm. And it has 85.3% sensitivity for diagnosis of stage 1 epithelial ovarian cancer. You have carcinomembryonic antigen, CA19.9 and CA15.3. BSCG, alpha-fetoprotein, and LDH are used mostly for malignant ovarian germ cell tumors. Inhibin is used for granulosa cell tumors. So we have CA125, HE4, then carcinomembryonic antigen CA19.9, CA15.3, then we have BHCG, alpha-fetoprotein, and then the LDH for malignant ovarian germ cell tumors, and inhibin for granulosa cell tumors. Prognosis has been historically based on age, performance status, FIGO stage, histology, grade, residual tumor, and ethnicity, race. And also in the last years, the specific mutations, the screening for the specific mutations is becoming to be a valuable prognostic factor too. So epithelial ovarian cancer is considered a chronic disease since approximately 80% of patients diagnosed with ovarian epithelial fallopian tube and primary peritoneal cancer will relapse after first-line chemotherapy. So there is a frequent relapse. Moreover, overall, more than 50% of women will eventually die from their disease. The standard of care is debulking surgery with optimal cytoreduction, that is, all lesions of more than 1 centimeter are excised in association with chemotherapy. There are 2 treatment options for advanced stage ovarian cancer. A surgery followed by 6 rounds of chemotherapy, one every 21 days, and neoadjuvant chemotherapy with 3 cycles, plus surgery plus adjuvant chemotherapy, 3 cycles. So we have 2 treatment options: surgery followed by 6 rounds of chemotherapy, or neoadjuvant chemotherapy, surgery, and adjuvant chemotherapy. The rationale of cytoreduction is based on the Goldie-Coldman hypothesis. That is, the higher the residual tumor volume, the higher the likelihood of chemoresistance. Optimal debulking is influenced by a variety of risk factors, the most important being performance status, age, level of tumor dissemination, and surgeon expertise. We have hysterectomy plus bilateral salpingo-oophorectomy is associated with peritoneal washing, omentectomy, lymphadenectomy, and multiple peritoneal biopsy. Surgery can also be used for symptoms palliation. The second first-line chemotherapy is carboplatin plus the standard first-line chemotherapy is carboplatin plus paclitaxel. In fact, platinum is a very active compound against epithelial ovarian cancer. A new frontier is tailored treatment after molecular pattern characterization. It is used in combination with standard therapy and is able to improve progression-free survival. Most commonly used compounds inhibit VEGF and EGF receptor activation signaling, or DNA repair, for example, PARP inhibitors, particularly ARPF in BRC, in BRCA mutated frames. Belinostat, a DNA acetylase inhibitor, isn't approved in Europe. Bevacizumab, an anti-VEGF antibody, is a drug which efficacy as continued therapy has been established. So, bevacizumab is also a used drug. Then we have borderline ovarian tumors. They account for 15% of all surface epithelial ovarian stromal tumors. The mean age of presentation is 40 years. Staging is based on FIGO score, and 70% of the patients are diagnosed as stage 1, so the tumor is linked with good prognosis. The main encountered histotypes are serous, 50% of cases. In 40% of times it's bilateral and associated with exovarian implants. Then we have mucinous, 40% of cases. It might be of gastrointestinal origin, especially if ovarian involvement is bilateral. Stromal invasion is usually not present, but non-destructive microinvasions can be detected. The diagnostic gold standard is ultrasound, even if it can be challenging because of some sharing features between benign and malignant masses. The most important prognostic factor is the surgical staging. Given the good prognosis and young age of patients with borderline tumors, it's important to carefully evaluate the choice between conservative surgery, which is unilateral salpingo-oophorectomy when the tumor is bilateral or a previous salpingo-oophorectomy was already been performed. Strict ultrasound follow-up is required. Conservative surgery harbors a 10% recurrence rate, but recurrences are mainly of borderline nature and located in the ovaries. Extravariant relapse is rare, 2% of cases. Relapses can be treated with conservative surgery as well. Then we can have radical surgery, like total abdominal hysterectomy with bilateral salpingo-oophorectomy. However, remember that the preservation of oncological safety must always be the leading factor in the surgical decision, obviously. So, how can we treat this borderline ovarian tumors? Let's repeat: with conservative surgery, and which has anyway a 10% recurrence rate, or radical surgery with total abdominal hysterectomy with bilateral salpingo-oophorectomy. In case of peritoneal implants, it's important to perform omentectomy because lavage and biopsies. It's important to perform omentectomy, peritoneal lavage, and biopsies in order to rule out malignant features. There is no evidence that chemotherapy can decrease relapse rate or improve survival. Finally, we have sex cord stromal tumors and malignant ovarian germ cell tumor. Sex cord stromal tumors are rare tumors arising from theca granulosa, Leydig, or Sertoli cells. Most of them have a benign course, slow progression, and are detected at early stages. That is, they have a good prognosis. 60% of them have detectable secretory activity. You have granulosa cell tumors and Sertoli-Leydig cell stromal tumors. Granulosa cell tumors typically show aromatase activity, that is estrogen secretion. The adult type, 90% of cases, mean age of presentation is of 50 years, is associated to estrogen-induced endometrial alteration. Atypical bleeding endometrial follow-up is essential, whereas the juvenile type, 5%, is associated to precocious puberty, breast enlargement, and abdominal pain, spontaneous rupture. Inhibin can be a useful tumor marker too. Prognosis is good, but long-term follow-up is necessary. Certainly Leydig cell stromal tumors have a mean age of presentation of 25 years. Then we have malignant ovarian germ cell tumors, which account for 5% of all ovarian tumors, typically presenting in a young fertile age. They have a high mitotic index and chemosensitivity is high. We have several histotypes which can be identified and are divided into non-differentiated germinomatous, which is this germinoma, and differentiated non-germinomatous, embryonal carcinoma, teratoma, and yolk sac, endometrial sinus, tumor and choriocarcinoma, yolk sac tumor and choriocarcinoma. They are more aggressive and prognosis is worse. So non-differentiated germinomatous, this germinoma, and differentiated non-germinomatous, which are more aggressive. Different markers are associated with each subtype. There are many, as we see here. Anyway, standard treatment is conservative surgery plus adjuvant chemotherapy. That is PEB, cisplatin, etoposide, bleomycin. Salvage chemotherapy is an option too. So let's review everything. We have endometrial cancer, epidemiology, risk factors, increased estrogen exposure, increased age, and genetics. We have two types. We have type 1, which is the most common, estrogen dependent, good prognosis, P10 mutations. Type 2, older women, lower survival, non-estrogen dependent, P53 mutations, poor prognosis. We have FIG surgical staging system. Diagnosis is done with endometrium biopsy and also with ultrasound, hysteroscopy, and CT MRI. Treatment is total hysterectomy and bilateral salpingo-oophorectomy. Uterine sarcomas, 6% of all uterine corpus tumors. There it can be divided into carcinosarcoma, leiomyosarcoma, endometrial stromal sarcoma, and adenosarcoma. Total hysterectomy and bilateral salpingo-oophorectomy is also the standard treatment here. Primary ovarian cancer, the risk factors are age, family history, genetic susceptibility with BRCA1, BRCA2, and HNPCC mutations, and the typical endometriosis, and also smoke, obesity, and asbestos exposure. We have the incessant ovulation theory, which is a way to explain pathogenesis. We have different subtypes like surface epithelial ovarian stromal tumor, which is subdivided into benign, borderline, and malignant. Malignant can be serous, mucinous, endometrioid, or clear cell, or Brenner tumor. The epithelial ovarian cancer, which is the malignant one, can be type 1, low grade, corresponds to low grade serous, low grade endometrioid, clear cell, and mucinous carcinoma. Type 2 corresponds to high grade serous, high grade endometrioid, and choriocarcinosarcoma and undifferentiated forms, P53 mutations, poor prognosis. Presentation usually symptomatic, and the symptoms are mainly associated to compression of surrounding structures. Diagnosis is done by bimanual pelvic examination and Doppler sonography. We have also tumor markers like CA125, HE4, CEA, carcinogenic antigen, CA19.9, CA15.3. Then BHCG, alpha fetoprotein, and LDH, and also inhibin. How can we treat it? We have debulking surgery, with optimal cytoreduction and in association with chemotherapy. The standard first-line chemotherapy is carboplatin and paclitaxel. Borderline ovarian tumors are mean age of presentation is 40 years, staging FIGO scores, main encountered histotypes are serous and mucinous. The diagnostic gold standard is ultrasound, and most important prognostic factor is surgical staging. For the treatment, we can do conservative surgery with unilateral salpingo-oophorectomy and radical surgery with total abdominal hysterectomy with bilateral salpingo-oophorectomy. Sex-cord tumors are rare. They can be granulosa cell tumor or certainly Leydig cell stromal tumor. We can have mean age of presentation of 25 years, and we can have malignant ovarian germ cell tumors, which typically present in young fertile age. Chemosensitivity is high. They are divided in non-differentiated germinomatous and differentiated non-germinomatous, which are more aggressive. Standard treatment is conservative surgery plus adjuvant chemotherapy with cisplatin and opposite bleomycin, which is by the way the standard of care for seminomas.